Good morning, everyone. Thank you for being here. My name is, I am State Senator Julie Mayfield. I represent Asheville and much of Buncombe County. Responsible leaders know that the number one rule for running a successful organization, be it a billion-dollar publicly traded company or a small nonprofit, hire good staff, put them where they can thrive, and give them the resources they need to be successful. This is what leaders do when they care about the quality of their work and the people who work for them. We have yet to see this kind of leadership from HCA. Had we seen it over the last 5 years, CMS would not have issued an unprecedented 9 findings of immediate jeopardy. And had we seen it in the plan of correction, we would not be here talking about the inadequacies of the plan. Hospitals are complex entities with lots of moving parts, but there are some simple rules that apply regardless of complexity and size. Hiring enough staff to do the work is rule number 1, especially when you have the money to do it. But hiring sufficient staff is not part of HCA's playbook, which seems to be written primarily to ensure a good return for their shareholders. And as an aside, I just have to note HCA's recent admission that providing quality health care, at least here in Asheville, is apparently also not in their playbook. The remedies contained in the plan of correction will certainly help address problems at Mission. But overall, we believe that the plan of correction is insufficient to address the shortcomings evidenced by the immediate jeopardy findings. We further believe that implementation of the plan of correction as approved will continue to leave patients at Mission Hospital at risk of harm. At this point, because the plan of correction is approved and being implemented, we are left to wait and see. We have encouraged CMS and DHHS to be vigilant, aggressive, and insistent in their future investigations, that they ask hard questions, and importantly, that they interview staff apart from management. And of course, we will continue to report issues as they come to us. When this plan proves to be insufficient, and we are convinced that it will, we call on CMS to be more aggressive in the next round and to actually require HCA to hire enough staff, put them in the right places, and give them the resources they need to provide the best care possible. Today you will hear from several individuals who will address different parts of the memo that was sent to DHHS on Tuesday. But first we're going to start with a statement from Holly Jones representing Attorney General Josh Stein. Thanks very much.
Thank you. I have a very short statement that the Attorney General wanted me to share with you all this morning. I continue to be extremely concerned about the way Mission HCA is treating its patients. I've alleged in court that it is not meeting the agreements it made with my office when it purchased the hospital, and I will continue to do everything in my power to improve health care in Western North Carolina.
Good morning. My name is Molly Zinker. I'm a nurse at Mission. I'm in the staffing pool, so I work on many different floors in the hospital, meaning I get a broad view of what is happening there. I'm here today in a role I do not want. Frankly, I hate public speaking. I want to simply be at the bedside caring for patients. I'm here today out of pure frustration because nurses are not being listened to. For years now, we have been providing a solution for nearly all the issues in the hospital. And while it appears that HCA has come up with a plan that took them 384 pages to explain, I can give you a solution in one sentence. Hire and retain staff. We need nurses and doctors, nursing assistants, physical and occupational therapists, speech therapists, clergy, lab personnel, phlebotomists, environmental staff, dietary professionals. It takes the expertise and the coordination of all of these people and more to provide basic care. Again, hire and retain staff. That is not a difficult idea or an impossible goal. However, HCA doesn't like it because it means spending money to hire good staff and treating them well enough that they want to stay. When patients come through those hospital doors at their most vulnerable state, they aren't seen as people seeking life-altering, life-saving care. They are dollar signs to HCA. And no matter how much HCA tries to deny this and placate everyone, they are lying. They are profit experts, and this is only a business to them. So I am here today to reiterate what nurses have literally been yelling from the streets of Asheville. If you want to fix the hospital, you need to staff it appropriately. You will not fix the problems at Mission by making nurses dust behind computers. You will not mend the gaping wounds by making us chart more. You will not improve patient care by mandating we do online learning that educates us that people need to be bathed and fed. We are educated, hardworking, caring professionals that are experts in patient care. We show up every day, and we do the best we can with what we have. We are the ones pushing ourselves to make Mission a place patients can still trust with their lives. Now, it's time for administration, the likes of Chad Patrick and Rob Lowe and Melanie Wetmore, to show up and work as hard as we do with us to make this hospital a safe place for people to seek care. The nurses at Mission are not fooled by the paltry efforts HCA has made to remove the hospital from immediate jeopardy. But I promise the nurses at Mission will not stop fighting for this community. We will not lie down. We will not be bullied. We will continue to advocate for the health and well-being of the people, our families, our friends, and our neighbors in Western North Carolina.
Just as an aside, I think we may have hit on a solution for the staffing, and that is to actually get Rob Lowe instead of Greg Lowe at the hospital. And I think we would get a lot of people wanting to come work at the hospital. So, yeah.
Molly Zinker. V-E-N-K-E-R.
I would go to the hospital with Rob Lowe.
Good morning. My name is Karen Sanders. I'm an RN patient advocate in private practice here in Asheville, North Carolina. I've lived here for 37 years. I worked at Mission Hospital for 16 years, Transylvania Regional Hospital, 7 years, and Care Partners for 1 year. I am here to speak to you about several things. First, I want to say I am speaking to nurses, unit secretaries, CNAs, physicians, pharmacists, central sterile processing staff, and other healthcare workers. Thank you for your great work at Mission, at HCA. I am speaking to all of the union nurses working at Mission. Thank you for your great work. I am speaking to the Centers for Medicaid and Medicare staff and the North Carolina Department of Health Service Regulation staff. Thank you for your findings and great work. I am speaking to members of the press for documenting patient care issues at HCA. Thank you for your great work. I am speaking to the members of the Mountain Maladies Facebook group and founder Will Overfelt. Thank you for your great work. I am speaking to the people in Asheville and 19 Western North Carolina counties, and I am speaking to HCA board members and senior leaders. Number one, 4 patients died at HCA in 2022 and 2023 were related to inadequate RN staffing in the ED as cited in the 384-page CMS report that was documented on February 15th by Asheville Watchdog and on the website. And in this article, it was CMS report dissects, another article, CMS report dissects widespread failures at HCA Mission Hospital by Andrew Jones and Sally Caston. We thank the Watchdog staff and Andrew Jones for submitting a Freedom of Information Act to obtain this information for our community and for our state. Number 2, Federal Regulation 42 CFR 482.23b requires hospitals certified to participate in Medicare, quote, have adequate numbers of licensed registered nurses, licensed practical nurses, and other personnel to provide nursing care to all patients as needed. Thanks to Julie Mayfield for leading a coalition of physicians and others to continue to bring these patient care issues to you. Number 4. In the article, The Importance of Optimal Nurse-to-Patient Ratio, in 2016, California was the only state in the U.S. that had legally defined required nurse-to-patient ratios to be maintained at all times by every unit. So nurse-to-patient ratios in the ED must be 1 to 4 patients, and ICU in the ER have a 1 to 2 patient ratios. That's ICU in the ER, that's critically ill patients in the ER with a 1 to 2 patient ratio. If these ratios are safe enough for human beings in California, these ratios should be adopted at HCA. 12 other states are now working on legislation about nurse-patient ratios. Number 5, these issues should be concerning and a wake-up call for everyone in WNC. The situation is a matter of life and death. Senior administration must be held accountable for these clinical outcomes. Number 6, we are demanding that the following changes occur regarding RN staffing at HCA and that there is evidence of these changes which can be reported in the Asheville Watchdog or Asheville Citizen Times or WLOS. A, documentation of RN patient ratios. What are the RN to patient ratios in the ER for non-emergent patients, and what are the RN to patient ratios for critically ill patients in the ER? Number 2, what is the total census of patients in the ER, and what are the plans to retain and recruit the numbers of qualified, competent RNs? Number C, what are the expected core competencies of RNs who are working in the ER? Number D, what is the plan to hire more unit secretaries, certified nursing assistants, phlebotomists, and housekeepers in the ER? Number E, how many RN vacancies are there currently in the ER? Number F, what is the procedure for utilizing SBAR, that's Situation Background Assessment and Recommendation, or otherwise known as an end-of-shift report, or used when you transfer patients by RNs? And we know from the literature that 80% of all medical errors occur during transitions of care, and patients being admitted to the ER or transferred to other units are examples of transitions of care, including change of shift report. Number G, what is your algorithm or plan to close beds in the ER when you cannot safely provide RN to patient ratios that are safe? If HCA cannot substantiate that they have enough RNs to maintain safe ER or RN staffing ratios, then ER beds must be closed immediately until such time as there are adequate RNs to provide care for these 8 at-risk patients. 7, these are takeaways. Patients, families, community, nurses all continue calling the North Carolina Division of Health Service Regulation to lodge your complaints, 800-624-3004. Put this number in your phone. Number 2, call the AshevilleWatchdog.org and ask to speak to Andrew Jones, or the Asheville Citizen Times and ask to speak to Mitch Black. Number C, oh yes, and WLOS. Would you say your name? Kimberly King, thank you. Number C, always take someone with you to the hospital to observe your care, ask questions, document your experiences, and make phone calls to the nursing staff or hospital staff, neighbors, friends, church members, and professional advocates. Thank you.
Good morning, everyone. My name is Dr. Robert Klein. I'm a family physician and former Mission Board member, and I'm here to address the target compliance levels in the CMS Plan of Correction. In response to CMS discovering 9 immediate jeopardy conditions at Mission Hospital, HCA proposed and CMS accepted a plan of correction with target compliance levels of 90%. Note, there are approximately 100,000 patient encounters at Mission ER every year. Therefore, despite the seriousness of harm to and death of patients described in the CMS sampling of cases over just a 2-year period, HCA's remedy would expose 10,000 patients every year to potential substandard care with catastrophic consequences. Of course, even one preventable death is too many. Do we accept an airline industry to pass scrutiny just 90% of the time, translating into conservatively an airliner crashing twice every day throughout this country? How about your surgeon washing her or his hands 90% of the time? I ask HCA shareholders, is that okay for your surgeon? Such a low bar is unacceptable, especially in a hospital. In addition, HCA's proposed monitoring would last only 5 quarters. In light of HCA's ongoing degradation of our hospital for the last 5 years, with transient respite only when regulators appear, this is completely inadequate. In summary, we draw your attention to a deeply flawed plan that does not emphasize requisite quantity nor experience of nursing personnel, as well outlined by Karen and Molly, fails to ensure adequate care for 10% of all patients, and limits oversight to a mere 15 months. We therefore respectfully request frequent, unannounced inspections and detailed monitoring during the time provided in the plan of correction. We further request that the North Carolina Department of Health and Human Services extend the monitoring period and significantly raise the target compliance level. Thank you.
Good morning. My name is Michael Messino. I'm a retired oncologist that happens to have his name on a building. I've been here since 1990, started the practice, and continue to be active, although not particularly seeing patients directly. I would like to address point number 3 in our document regarding the plan of corrections for HCA Mission Hospital. This point is withheld documents and incomplete interviews. When reading the extensive report, there's one fact that stands out and is quite concerning. HCA repeatedly withheld documents from DHHS surveyors. Often the surveyors could not actively hold needed documents and often did not follow up with requested documents or interviews. Repeatedly, comments were made that the requested interviewee was not available. They were there 3 weeks, not available. One specific case resulting in a death, all records were not made available, and I can state that the family continues to have difficulty getting these records weeks after the death. This has nothing to do with DHHS, but rather is further example of interfering with record acquisition and HCA. Withholding documents and not allowing the surveyors to actively see the requested documents is absolutely unacceptable. It is appalling that HCA would do this, but it's no surprise. And I'll repeat that, it's no surprise. HCA has walked a fine line for many issues here and at other facilities. This is a norm rather than a variation for HCA. Remember that one administrator repeatedly said that much of what is being said around is anecdotal. Not being able to speak to the necessary staff involved in the case and just writing that the staff was not available for the interviews seems very wrong. DHHS was there for 3 weeks. They had a tremendous job to do, and we're not criticizing the job because 9 immediate jeopardies is an incredible number. Just dealing with one would be a lot of work. So where were these staff members over the 3 weeks? This kind of avoidance should call attention to trying to hide information which would shed light on the seriousness of a case or why the outcome was disastrous. Were these staff members told to stay away, or as one staff member stated, quote, they were told that they did not have to speak to the surveyors, end of quote. Because of the seriousness of the issues at hand, this type of hiding or manipulating the truth should be reprimanded and corrections in any of the lost details re-examined to gain the truth of the incident at hand. How can a state and federal agency investigating wrongdoing be denied access to any information that is requested? Besides being dishonest, this is very disrespectful to the agency and to its mandate for patient safety. Given the seriousness of harm and deaths of patients detailed in the CMS report, we strongly urge that as part of any follow-up monitoring and inspections, the interviews that were not conducted be completed and all documents requested be turned over to DHHS for further review. We further request that all further investigations require complete transparency and documenting evidence. I do want to make one note regarding the staffing issues. I wish to address staffing issues as well. HCA has no respect for the staff. They assume that one's title, degree, means, quote, can do any jobs. And that fits near the qualifications of the position. For example, being an RN means that you can work with any patient. That's so wrong over the last 15 years as we've become more specialized in medicine. A medical surgical nurse is not an ER nurse or an ICU nurse or an obstetrical nurse. So why would they be expected to go somewhere and do a job that they're not familiar with? Well, they're an RN. That's Mr. Lowe's thoughts. As with all occupations, there are basics that are learned, but it is the specialized training that separates us all from our colleagues doing another specialty area. HCA feels that they can move people into areas that are unfamiliar with and expect them to fulfill the role well enough to get by. It's always to get by. This is a dangerous practice and results in harm. The same is true for physicians, pharmacists, radiology technicians, and most areas of medicine. Training and experience make for excellent healthcare providers and for an excellent healthcare system. HCA needs to learn this, spend the money to fulfill the roles for safety and quality and respect to the people that are working at the hospital. Thank you.
My name is Missy Harris. I am co-pastor of Circle of Mercy Congregation, and I worked at Mission for close to 6 years as a chaplain and as a support person for folks who were in situations where they were having to make decisions around organ donation when their family members were determined to be brain dead. Reading this report has been infuriating and emotional. As someone tasked with the spiritual care of people within Mission Hospital for many years, these accounts, while not surprising, are still utterly heartbreaking. The comments of my colleagues I saw daily as I worked there at Mission. As a chaplain, I worked in every square inch of the hospital, every unit, department, and in the middle of COVID, even in the depths of PPE distribution to staff, and had constant interactions with the folks who are working in sterile processing. The things that I saw were unconscionable, and I reported all of the things that I felt were unconscionable. Those don't show up in this report. If you decide to delve into this report, steady yourself. It's not easy to read, especially if you're someone who feels any amount of empathy or tenderness toward patients, families, staff members who have had to endure all of this. And I want us all to remember that we're not reading about unnamed patients, number 1, number 2, number 6, number 28, number 29, number 43, number 66, number 83, or number 92. We are reading about mothers and fathers, siblings, friends, teachers, students, patients, doctors, nurses, our neighbors. Each of these numbers is a human being whose medical histories we know way more about than we should. Each of these numbers represents someone who has walked or is walking among us now. Each of these stories are connected with us in ways that we will never know. One of the tragedies around this report is the fact that for some patients and families, this is the first time that they're learning of some of these details, reopening and deepening the trauma, wounds, and grief that they have already walked through after these situations that impacted them and their family members. I want you to also remember that we're not reading about unnamed medical personnel and support staff when you see PA number 90, or RN number 88, or RN number 54, or MD 62. Their stories extend far beyond what we know about them in this report. They are understaffed medical and support personnel who were stretched to their limits, doing the very best that they could with what HCA has given them, which is very little. They carry these soul-deep stories with them in ways that you and I will probably never have to know and feel. The conditions in our region's hospital outlined in this report were not a problem until the arrival of HCA in our community. Responsibility for the deficiencies belongs squarely on the shoulders of HCA executives who consistently have not provided our medical personnel with the staffing levels and resources that they need to do their jobs fully. We as a community and region cannot allow our medical personnel and support staff to bear the brunt of responsibility for outcomes that belong solely to executives who are more driven by keeping shareholders happy than providing patient-centered, safe, affordable health care in our community. Things weren't perfect before HCA arrived. That said, Mission Health has never received a 384-page report outlining a litany of systemic failures that have caused widespread harm and, most regrettably, loss of life. HCA's failures have diminished our highly respected healthcare system, leading to a loss of trust and confidence in the delivery of care that had taken decades to build. It leaves us wondering how and when this can be rebuilt. HCA, over 5 years of ownership, has demonstrated that they do not have a commitment to deliver dependable, safe, quality, affordable health care within our community and region. The report only covers egregious situations primarily in the emergency department over the past 2 years. And as someone who worked at Mission before and after HCA's purchase, particularly in the height of the pandemic, I am left wondering what other stories are buried in their vaults that would horrify and haunt us even more than what we've read in this 384-page report. As previously said by my colleagues, they haven't even been willing to share information, documentation, and staff interviews requested on these cases outlined in the report that was made public last week. So we all stand here today to ask DHHS and CMS to continue their due diligence in monitoring these issues, to heed our collective voices and reassure this community and region that HCA will be held accountable. One concrete suggestion that I would offer is that HCA reconvene the Bioethics Committee, which they disbanded over these past 5 years, and that it be led by a trained ethicist who would help guide this system of accountability. HCA, you need to know that we are paying close attention. And I once again want to point to your brilliant marketing and PR campaigns. You're really helping us out here. On January 16th, you posted a photo of Martin Luther King Jr., accompanied by one of his quotes, which read, "Life's most persistent and urgent question is, what are you doing for others?" HCA executives, I do hope you're wrestling with that very question right now in light of the harm that you have brought to this region and community with your profit over patient care business practices. What you have done to our healthcare system has brought deep pain and harm to people of this region and community. And for some, your inactions have had life-ending consequences. We are not willing to stand by quietly while this callous behavior and these appalling decisions continue within our healthcare system. The holy and sacred work of healing should be the #1 priority throughout the entire hospital, starting with the leadership working in the C-suite. The devoted staff need your full commitment to support and meet this goal. We will settle for nothing less. We continue to call on everyone in this region to join us in speaking out. We need you to pay attention and heed this call for change. It's time for every Western North Carolinian who is able and willing to do so to rise up and state these three things clearly to HCA. We want our health care system back now and the quality of patient care to be restored. 2, we are not backing down. And 3, if you all don't know it already, you have greatly underestimated the power and tenacity of this community and region. Thank you.
All right, those are all the planned speakers. I do want to acknowledge a couple of the other folks who have joined us up here today. We have some physicians, Dr. Alan Lawler, Dr. Clay Ballantyne, Dr. Bruce Kelly, and then we have some elected officials, county commissioners, Al Whiteside and Amanda Edwards, and then Representative Caleb Rudow as well. And then another key member of our coalition, John Nicolay, who is working with neighborhoods and others around the region. So we're happy to stand for questions if folks have them.
Can I add one more thing?
Absolutely.
Just within the past 24 hours, I have had conversations with 4 different people who are employed at Mission. And in each of those cases, they have named a lot of what we have named here that has happened within even the past 2 to 3 weeks. In the time period that HCA is supposed to be addressing these deficiencies that have led to these situations of immediate jeopardy. So these things are still happening within the hospital, and we have to hold their feet to the fire around all of this.
So any questions from anyone for anyone up here?
Curious about DHHS and the acceptance of the plan that many of you feel is inadequate. I believe Cody Kinsley, is he the secretary?
He is.
Senator of DHHS for the state of North Carolina. Have you had any face-to-face conversations with him? These repeated press conferences, while our community is clearly watching it, we cover it on the news, there are multiple news agencies covering this. At the end of the day, these are people that are paid for, they are employed by taxpayer dollars. We have never been able to interview him. What has he said to you? And is he involved at all in the way that Josh Stein is in trying to prosecute this case?
So a number of us up here have met with Secretary Kinsley, and I think we would all agree that he is extremely concerned about what's happening here, and is committed to addressing the concerns that are here. I have not spoken with him in the last month about this recent situation, the immediate jeopardy findings, but I have spoken and communicated repeatedly with his chief deputy, Mark Benton, to whom the memo that we wrote is addressed. That line of communication is open and flowing, and I will certainly pass on the desire for their staff to be more available to the media. I will also remind everyone that in this context, DHHS is essentially the contractor for CMS. So CMS is the entity in charge of this process, and DHHS works for CMS. So when CMS decides not to publicly release documents, certainly on the timetable that we would like, that's a CMS decision, not a DHHS decision. And so we need to be careful to sort of put the concern in the right place. As I think Karen indicated, we do have DHHS to thank for this extensive report that resulted in the findings of 9 immediate jeopardies, and we are grateful to them for doing that. And I will note, I think people know this, but DHHS and CMS are in the hospital this week inspecting and surveying to determine compliance with the plan of correction. They continue to be, they came on Tuesday, I believe, and they continue to be there today. CMS's presence, I take as an indication of their understanding of the level of seriousness that is at play here. Again, we have encouraged them to be aggressive and vigilant.
Oh, I'm sorry, I'm going to do a quick follow-up.
Yeah.
Many of you here, I interviewed a doctor yesterday who said that staffing is the bottom line, the understaffing. And the doctor shared with me here today, Dr. Lawler said that there's only a paragraph in this document that mentions staffing. So again, I go back to DHHS, whether it's CMS, the administrator, I see the federal administrator, Chiquita Brooks-LaSure. I don't know if you've ever talked to her. Why is, you are here today to say that this is not enough, and the bottom line is the staffing. What do you want to say to them about that they accepted this plan of action from HCA, and yet it's that the bottom line for you is not in here?
I think we're saying it. I think the question, sorry, to repeat the question, what are we saying to CMS and to DHHS? And I think we've said it. We've said it in our memo. We've said it repeatedly here. And we will continue to say it because we know that that is the answer. And we also know that that is the place that HCA is going to continue to resist because that is the thing that costs them money. That is the thing that costs them money. And I'm sorry, but HCA, you are going to have to spend money to fix this problem. It is not going to go away, as we said, with huddles and documentation and education modules. That is not the answer. Not to say that those things can't help, but that is not the answer. And we all know that. Does anybody else want to add to that? Okay. Any other questions? Yeah.
What is the next date?
Oh, sorry. You want to add to that? Go ahead.
I'm Dr. Alan Lawler from the ER. I worked at Mission Hospital for 27 years. To their credit, DHHS and CMS continue to pull records this week. They have pulled the records on a patient in acute alcohol withdrawal with what's called a CWA score of 19, which is extremely high and puts them at risk, significant risk of death. So we applaud their continued efforts to try and make HCA do a better job.
Alicia.
What's the next date that we should, be looking at when it comes to this process and how it's playing out? And are there, as Dr. mentioned, will there be more details coming out about the cases that have already been made public or other things that are being uncovered?
Yeah, so the question is, what's the next date that we should watch out for? The next date is February 24th, which is day 23 in the immediate jeopardy game, so to speak. And that will be the date upon which DHHS and CMS will need to determine whether HCA is in compliance with the plan of correction. So we will wait to see what that is. As Dr. Lawler just indicated, CMS's investigations can be ongoing. They can continue to investigate particular instances. Many of the folks up here continue to forward stories of concern that we have to DHHS for investigation, and that will not stop. That will not stop. As Missy indicated, the behaviors that and the continued systemic failure of HCA to provide enough staff and resources continue today in many parts of the hospital. And that will continue to result in patient harm. And we will make sure that the regulators know about that, and we will be calling on them to make continued findings as appropriate. Anybody else?
Just a quick follow-up on that. Do we know, will DHHS or CMS make some sort of public statement on whether they found?
I would expect them to, and I would expect them to. Yeah. Mike, okay. Anybody else? Okay. Oh, Mitch. Yeah.
So the plan of correction is a tool that, the hospital needs to submit in order to get back into substantial compliance with Medicare regulation that's been accepted and how you're criticizing it. Is this a flaw in the actual legislation, the federal legislation that governs Medicare compliance, or is it a flaw in CMS's interpretation and enforcement of that legislation?
I guess I would say that it would be a flaw in the law. So my understanding is that that part of the process did not vary from what is normal, that CMS took and reviewed the plan of correction and approved it without making it public. And if that is what happens normally in this arena, then that is what happens. I will say in the arena that I normally work in, which is the environmental arena, there is always opportunity for comment, public comment on documents like this, significant documents that will bind people's behavior and companies' behavior going forward. And you know, it is unfortunate that this is the way that system works, because it does not allow, again, the expertise of the people that you see in front of you and others to bear on the plan of correction. I think our memo says collectively we have 200 and what was the number? 290? 231 years of experience of the folks up here working in the hospital and within the mission system. And I'm just going to say, I think the folks up here know how to fix this problem more so than CMS investigators who are coming in from the outside.
And another question, part of the reporting that is lined up in this report is to give reports about compliance ratios to a bunch of internal departments and the Board of Trustees. Have you requested to see those reports? Do you think it builds public trust if that is an internal process?
No, I do not think it builds community trust if that's an internal process. I certainly understand why the hospital would treat it as an internal process. Again, HCA has never sought and has affirmatively rejected outside help to address the problems in the hospital. That is not what they do. Again, they have a playbook. They run by their playbook. Their playbook doesn't work here. They haven't figured that out yet, but we're happy to continue to tell them. But no, I do not expect them to seek any outside assistance at this point.
And so you and Representative Ruda have had a front row seat to this months-long survey process. Going into the upcoming legislative session, do either of you plan to submit any legislation to fix what you see as the flaws in this process?
Well, so I'm thinking about legislative solutions on a number of fronts, and Representative Ruda might be as well. I think the problems here, though, are not governed by state law. I think they are governed by federal law and federal regulation. So we cannot change those.
And I'll take a crack at that too. You know, I'm also running for NC11 congressional district, and you know what you've seen from the congressional rep was that didn't want to talk about the issue, hasn't wanted to take any stance on how to push CMS or how to take an aggressive stance towards fixing this at a congressional level. And I think that's the kind of leadership we need for this district, and that's the kind of leadership that I think everybody here is looking for somebody to stand up and push for better legislation and push for CMS to take a stronger stance.
Do you have any bills that you think you would introduce if you were an elected member of Congress to fix some of the issues that you see in this issue?
I think the core of this issue is corporatization of medicine and lack of a system of holding corporate medical practices accountable. And I think this is what we've seen in North Carolina in the bill I worked on with Senator Mayfield, and I think it's the kind of thing that's happening all across this country and all across Western North Carolina. So if elected, I would sit down with folks and try to figure out how do we solve this issue that I think is really popping up everywhere. And Western North Carolina is just one example of a national phenomenon.
So go ahead, John.
Let me make one comment about DHHS's review. There was one case that took an immense amount of time and resulted in a death. And it wasn't even completely investigated because they didn't have the information. That's the case that I said they were still trying to get their records after the death. So if you think about that, all that energy for one case, and there's 8 other ones, I don't think that DHHS has ever had to look at that many cases and find 9 of them in jeopardy. So I want to give them a little bit of a break. I think they've done a very good job under the circumstances. And if they only had 1 or 2 cases, it would have been investigated much more thoroughly. So this is incredible to have 9 cases. And I can tell you up here, we all know of other cases. We know of other deaths that haven't been looked at yet. So there's plenty, as Senator Mayfield said, out there that hasn't been pulled in yet. And we'll keep looking, and we'll keep bringing it forward.
I wanted to name one more thing that does not show up in this 384-page report that touches on the understaffing and the pressure that is on our nurses. When I worked at Mission as a chaplain, I was mostly on the overnight shift, and most of my time, I would say probably 95% of my time, was spent in the emergency department. Even at the height of the pandemic, well, let me preface it by this. Prior to HCA's purchase, and I think Dr. Lawler can attest to this, when we were in the old emergency department, there were 2 to 3 EVS, environmental services staff members, who circulated around the department and cleaned every single patient room between patients. That was the standard of care and cleanliness in the emergency room prior to HCA's purchase. After we moved to the K building overnight, there are no EVS staff assigned to the emergency department. There's someone who cleans the floors, but it's up to the nurses. The work of cleaning rooms between patients falls on the shoulders of our nurses. I left in May of 2023, and I'm curious if that has changed. I spent time alongside nurses in the 4 trauma rooms in the emergency department with a container of hospital-grade Sandy wipes, and between trauma patients coming through, we all worked together with that that container of Sandy wipes to wipe up visible blood as best we could, and for the next patient to be rolled in. And the focus was on the trauma rooms. I don't know what was happening in the rest of the rooms in the Red Pod at the time, but it's unacceptable to put the weight of that work on our nurses, because it's impossible to get done. And those kinds of stories don't show up in this report, but they were happening every single shift that I worked.
So I'm cognizant of our time. If folks don't have any other questions, yeah, Mitchell.
Yeah, I've got one more. One of the things that you said is that this is primarily a federal issue, right?
Yeah.
This is an issue with CMS. Karen pointed out a moment ago that California actually has some nurse
Yes.
staffing laws. Is that something that you see that you would want to try to do in North Carolina? And do you think it's at all politically feasible?
So the question is about the state of North Carolina adopting nurse-patient ratios like California has done. I certainly have had that conversation with some of my Republican colleagues. At this point, it has not been well received. So I'm putting my efforts in pushing forward on other things that I think will have a better chance of passing. Yeah. But I do agree that is certainly part of the answer. So I just want to draw everybody's attention to something else that happened yesterday, and that is that you may have heard that the District Court for the Western District of North Carolina issued a decision in a case that is very important to us here in Western North Carolina. As you may recall, the City of Asheville, the Buncombe County, Madison County, and the town of Brevard, really led by Brevard, filed a lawsuit against HCA for engaging in monopolistic practices that have eliminated normal competition in the local healthcare industry, resulting in higher prices and lower quality of care. And not surprisingly, in response to that lawsuit, HCA filed a motion to dismiss all of those claims. After many months of waiting, finally yesterday, the judge issued a clean and complete denial of HCA's motion. This means that the lawsuit can proceed, and the parties will enter into a period of discovery that will allow the government plaintiffs to discover and seek information on HCA's business practices. I will also say that in addition, the government plaintiffs will be seeking to certify this case as a class action on behalf of all local entities who are self-insured. So The party continues. Thank you all again for coming, and thanks to the folks who are doing this work every day. I appreciate you being here. All right. Great job. Thanks, guys.
So